MRD, for those who don't know, stands for minimal residual disease, and it's a new set of techniques that are being applied towards the measurement of trace amounts of tumor cells being left behind. In myeloma, we have the fortune now that we have two types of techniques. The current one that's used the most is flow cytometry based. And with flow cytometry based, which is usually an 8 or a 10 color flow cytometry, one can get down to a level of 10 to the minus 5 cells. And we're now seeing emergence of next generation sequencing based minimal residual disease detection. There's actually a number of papers and posters presented at this meeting with one of the platforms that is being used. The reason it's exciting, first of all, is because it matters. It never mattered before because we never got to those levels of very deep responses. And actually MRD will become a key player in how we evaluate efficacy for the drugs, durability of responses, and certainly dynamic changes over time. So we're clearly excited. We think perhaps not now, but 5 years from now, this will be part of the standard armamentarium and should be considered for all myeloma patients. When people think about MRD in the case of hematological malignancies, it mostly focuses on first-line treatment, curative intent. So we didn't have that. We now have that in myeloma, and we're thinking, well, we're going to start doing MRD testing potentially as a prognostic marker, say at the day 100 evaluation. Well, it turns out that Aspire is presented at this meeting, and they're achieving complete responses of patients. I mean, in the setting of 1 to 3 prior therapies, you have about a quarter of patients who can get into very deep responses, including stringent complete responses. So now it might be relevant to those settings as well too, because the bar has been lifted. We're looking at much higher standards for what we would consider deep responses, and again, the fact that we're just talking about it in the setting of relapse and refractory disease is fascinating. Amyloidosis remains obviously a sister disease to multiple myeloma, and there were a couple of papers presented here, mostly showing the efficacy of proteasome inhibition in the setting of amyloidosis. So there's a number of papers that have been published. We have actually participated in one of those using CyberD for amyloidosis, and that was confirmed here by Dr. Merlini with a collaborative group from other European institutions where they show a very high level of activity of these drugs. I think the future for patients with amyloidosis is much brighter. They have the same type of cells, the same plasma cells. Usually they're not cells that behave malignant. The problem is it's just that they produce a bad protein. And what we're learning in myeloma, we can always extrapolate to amyloidosis with special adaptations and other considerations. But those two papers do show that the outcomes will become better as we can get deeper and more durable responses.